Okay, good morning, everyone. For those of you that don't know me, my name is Stephanie Apple, and I'm the Director of Administration and Financial Management. And I'm excited to be here with you all today to discuss the FY16 Local Health Department contracts. I know it's going to be a great day. I think you guys are scheduled until 12:15 or so, and I know you've got the best trainer right here, Tammy Page, that she knows everything there is to know about these contracts. So I know she's going to provide you with a fulfilling training today. So one thing I would remind everyone is to make sure to adhere to any timelines. I know we're on a strict timeline with the end of the fiscal year, new budgets coming in. So just to make sure that everyone adheres to the timelines that are put into place today. And I hope you enjoy the training. And so I'll turn it over to Tammy.
Good morning, I'm Tammy. And before we start on the PowerPoint, I really want to say how much I appreciate everybody out in the health departments and how much work you all have done this year on the FY15 contracts. I think it was a really good year, and I really do appreciate everyone's hard work. I just want to give you a little background. For this year, FY15, we had 1,898 contracts filed. This time last year, we had 1,913 contracts filed, so we had a few less this year than last year, but that's okay. I want to explain the process just a little bit so you can understand what we do here. When you save your contract on the L drive, I look at it and I determine who is going to review it, what program staff besides myself is going to review it. And then I email it to all program staff that's going to review it. So you could have a contract that could have up to 4 people looking at it. So once I send it out, and I wait until I get all their comments back, and then that's when I send you your comments. So that's the process. So if you have any questions, if you're confused about that, you can give me a call. So let's go ahead and start the PowerPoint. And I'm not going to read every PowerPoint to you. You all can read them. I'm sure some of it might be redundant for you, so we'll go through it pretty quickly. This is the reg that we refer to, 902 KAR 8170, Local Health Department Financial Management Requirements. I would suggest if you don't have that available at your desk, that you make a copy and put it in your drawer, hang it on your wall, because you will refer to it a lot. I look at it a lot when I have simple questions. Okay, the contract is between the LHD and the provider, and it should be signed by both parties prior to July 1st of each fiscal year. It should be signed regardless of whether we have looked at it or not. You should go ahead and get it signed. So technically, if it's not signed by July 1st, there's no effective contract in place. So once again, if we haven't reviewed it, that's fine. You need to go ahead and get it signed. Section 7, number 10, all local health department contracts and amendments are subject to review by the Department for Public Health. A few years ago, we used to not review them all, and now we do, just in case that you didn't realize that we're still going to review them all. Okay, the CH53M, the Independent Contractor Agreement. In the contract, you'll see there are gray highlights, and those highlighted areas are places where you need to insert something. So we need the service type, the contract description, the provider credentials, and we don't need a copy of their credentials. You need to keep a copy of those credentials on file. We need scope of work, the compensation/payment, the billing procedures, the amount, number 1, and the contract value, number 3, and the CH55, if applicable. Okay, the CH55 is only required for independent contractors, the CH53M. You don't need a CH55 if you have an employee contract. A 51, you do not need that because the health department is going to bill. The employee will not bill. So you only need it for the 53M. So if the contractor is performing the services on site and the health department is going to bill Medicaid on behalf of the contractor, that's when you need the CH55. There'll be an N at the top of that page where it says third party is the responsibility of the contractor. There'll be an N there, and that's when you would need the CH55. Are there any questions about that? So when the contractor signs that, they're allowing the health department to bill on their behalf. We really recommend that if the contractor is a Medicaid provider, that the contractor bill for the services performed off-site. Then the CH-55 would not be required. Okay, if the LHD is to bill the third party, this includes patients that are provided services by the contractor at the contractor site who have insurance, Medicaid, Medicare, etc., with the exception of lab services. For CPT codes not listed on the DPH Medicaid Preventive Fee Schedule, the health department will not receive payment from Medicaid. You need to make sure that those CPT codes are on that fee schedule. Once again, you should not agree to bill on behalf of the contractor if there are codes that aren't billable. Okay, on the last page of the CH-53M, the contract amount. Number one, you see you have the contract section and the amount. The contract section are the provider numbers, not the cost center numbers, and then you have your amounts. Now, number three, as you see, can be it's the 10,000 and the 10,000, 20,000 times 1.2, 24,000. So number one is 20,000, and number three is 1.2 more, 24,000. Now, if you wanted to do an amendment to your contract, you would use the amount that's in number one, not number three. You would use the 20,000 to base your amendment on. Can a contract have more than one provider number? Yes. A provider can have numerous numbers. Say you have a hospital, and it can have a nurse, you can have a mammogram, you can have lab services, you can have a room, and they can all be under one provider. And when you create the contract, the first page will be the boilerplate language where it says whereas and has some sentences there. That would only be on the first page of the contract. Then the rest of the contract would have all the information about each provider number. And you need to make sure that in the contract that each provider number has a third-party billing sentence. So if you have a contract that has say a 21501, so you would need to make sure that underneath that provider number you have a sentence about who's responsible for third-party billing. And then if you have a lab number, 25010, you need to make sure you have another sentence underneath that number in that section for third-party billing. Does anyone have any questions about that? Okay. Labs. The independent contractor is responsible for billing all third parties for labs. That's 201 and 250 numbers. So the third party, the independent contractor, has to bill for those. When the contracted provider bills the third-party payers, there are some services that we request you to report to the Supplemental Reporting System to obtain necessary federal and state data information. And those include mammograms, breast ultrasounds, PAPs, HPV, lead tests, and it's the CH-47, and I actually saved that CH-47 on the L drive if you need to look at it, and also you can see it can be found at that website. Okay, provider numbers. For medical services, provider numbers can only be 201 to 260. There are some numbers that are 301 to 315. Those are not for medical services. Do not use those. As I showed the example here, that 30115, that's not a medical service number. So make sure that you only use 201 through 260 for your medical services. Okay, in your contract, if you have Anesthesia, W0166. If your provider is providing anesthesia, then you need to have a 260 provider number in that contract with language. If your provider is providing anesthesia, I am so sorry, W0166 is a room. Yeah, I got confused. So if you have a room in your contract, you're going to do a 260 number. If you have anesthesia in your contract, you're going to have a 205 number. And there are examples of that language on the L drive. Once again, if you have W0166, you're going to have a 260 provider number in your contract. And if you have anesthesia codes, you're going to have a 205 provider number. Are there any questions? Okay, Janet Overstreet now will speak about the CH52.
Good morning, everyone. The part about the CH52, most of the information is the same as it has been the last year or two, but there are just a couple little things that might be a little different. So for most of you all that's participated in this training before, it'll just, you already know what we've got going on here. The CH52 is a standardized contract template that health departments can use to enter into contracts with public or private entities for any needed health services that the health department would be providing. It can be used for boards of education contracts and Payor Code 8 contracts, and then other contracts that are Payor Code 8 that where the your provider initiates that contract that is allowable, where you don't use the standardized 52, but as long as that contract has that you receive, and I know a lot of times the transportation department will contract with local health departments for some services. They like to use their contract as long as it's got the required language that we need embedded in it, and that the end date is June the 30th, then that would be fine. You can also use this contract when two health departments are contracting between each other for an employee. The first party in those type situations would be the health department requesting the employee, and the health department would be the one supplying the employee.
And
I'm not clicking.
the first party will write that contract. The first party is requesting the employee, so they're going to be responsible for writing the contract.
Okay, and as I said, the Payor Code 8 contracts, for the most part, should be between the health department and public and private entities. These contracts are not to be done with individuals to try to get services done specific for an individual. That would not be acceptable. Only time an individual can enter into a contract is if that individual is the public or private entity. Health departments have the ability to negotiate some higher rates. That would be the rates that are higher than what we have in our 501 service file. And there are a couple of exceptions with that, and we'll address them a little later. Your negotiated rate should not be less than what we have in the 501 service file. You want your rates to cover direct and indirect costs. And I can almost guarantee you that your costs are never going to be lower than what's on that 501 service file. Payor Code 8 agreements, with them you should have a HIPAA business associate agreement. Once you have your business associate agreement, you do not have to do it again unless there's significant language changes. And just a couple years ago, the omnibus rule did require everyone to redo their business associate agreements because there was some significant language changes and a redefinition of what a business associate is. So everyone should already have done that. But if you still have any that you haven't, please do so. You should do your Payor Code agreements prior to providing any services. You can do them anytime during the year. If it's an ongoing public or private entity that you contract with every year, you usually want to do that July 1 for the fiscal year. But you can enter into an agreement anytime during the year with those kind of folks. However, the ending date needs to be June 30th. Once you set up a Payor Code 8 contract, as far as I know, you still have to give them a number. You at the local level will assign a number for that, a contract code number, and you have to enter it, set it up in Bridge and in Portal. Now, I haven't been told any different, so I'm still under the impression that's how it has to work. And when you enter the encounters, for those of your staff that do that, then you put the contract code number in the field at that encounter entry screen, the one that's got CNTC, and then you would put Payor Code 8 on the line item as you enter where you've entered your CPT code, provider number, diagnosis code. Then in the override you would put P8. If you don't do it that way, it doesn't come out near as well when those reports print once a month. If you don't put Payor Code 8, it's not even going to assign it to Payor Code 8, so it'll charge the patient under Payor Code 1 most generally. If you put Payor Code 8 but leave the contract code off, you will get, it will come on the report, but it won't be listed with any other folks you have with that contract code. It'll just be contract code not assigned, and it'll be all the people that you may have entered that you didn't put a contract code, but you put Payor Code 8. Rates negotiated by the health department that are higher than the system assigned rates may be overwritten without submitting a request to AFM for approval. Now, this is allowed because we can only put one rate statewide in our service file, and we use the Medicare rate for our region, our state. And we do know that there's a lot of agencies out there that have higher costs. In some areas of the state, it's higher than others. It varies. So it's acceptable when you do these contracts if you can negotiate a more reasonable rate for your area with a provider or a contractor, that you can do so. We don't need you to send it up here to ask us if that's okay. We do ask you to enter a rate in there, and it cannot be set up as 0 or do not use a nominal fee, because one, that does not cover your costs, and you want your costs covered for those services because they are outside what your normal health department activities are. You're contracting with agencies that are willing to pay for their employees, so they need to be treated as third-party payers that will pay to 100% of the cost. Now, this would be, unless we identify something different, that's what you, that thought would be what you would apply to all those contracts. Now we'll talk a little bit about the FAST employees for the BCBS. And we've been in contracts with them for several years. And so with that, you do have them as, well, I have set them up as a 701 contract code. So that's okay, everybody. We're back from our unscheduled break. I'll kind of start maybe probably where I left off and I can't forget, I can't remember what this slide, what it said and what it didn't, so we'll just start here. This is about the Payor Code 8 and the DCBS agreement that we have. And this is for those employees out in the field at your local DCBS offices that have been designated as the first aid safety team. And those employees can schedule with your health department to get hepatitis B vaccinations or flu, and that's still part of the contract, flu. However, DCBS here at the state lets their field staff know that they would prefer them, highly prefer them, to use their health insurance to get their flu shots. And for 2 years now, we haven't had any flu shots being reported, being done through the health department through this particular contract. There's a document out there, and Tammy has put the document with the fiscal year 16 contracts. It's not, last time we had it updated with a list of by county of those DCBS employees that are on there as being designated FAST employees was in October of last year. If you ever have one that presents that's not on that list, let us know, and then we'll check with DCBS, because they're supposed to provide me with a new one if they have people that go off or come on it. So they only send a revised one rarely, like maybe once a year or something. So if that happens, just let us know. We also implemented a voucher that DCBS approved, and we worked on with them, that those employees may present with, and that's a better confirmation that, yes, they recognize them as a FAST employee and that they know they're going to get their Hep B. The vaccine administration rate in that contract is $22, and then the amount for the actual vaccine, the Hep B, would be the cost to your agency. And it's usually according to, we look at the CDC private sector price per dose, and it's most everybody purchases from Glaxo or SmithKline, and usually that comes out to be $75. It's usually $53, or at this point still. I think I just looked recently at the rate, and but Merck has a vaccine Hep B that's a little higher. The rate we have in the file is based on the Merck rate, because like I said, we can only put one rate in there, and we usually look at the highest manufacturer rate. So you would need to override according to the cost of that vaccine with your agency. So I really appreciate it if you do that. It's less work for me. Now, as I've done in the past, I'll be querying those quarterly with the 701 contract code. So if you don't get the 701 contract code on there, I will not be able to pick it up, and you may not get paid. So it's very important that you get the contract code on there for those hepatitis B's for the DCBS people. When I do it quarterly, then we pay the health department through our contracts and payments branch for those people that's on the list. And then in turn, we bill the cabinet or DCBS annually to get our refund back from them. Another contract that some health departments may do, and we don't have a standardized contract for that. We do put out there one like a sample contract that sort of that has information about the jail and the KRS and information on it. Some health departments or some jails want to contract with health departments to do some medical services. Usually it's just a few different things, or they're incarcerated individuals. And if you enter into those contracts, you do need to have on there and use the Kentucky Physicians Medicaid rate, because that's what the statute says, that's the rate it will be billed from. Now, the other thing that I've added here is information, or it's a link to the federal government in their healthcare.com. They talk about how ACA affects incarcerated people, and they define incarcerated people, and they talk about if your state has chosen to do expanded Medicaid and how all that works with those people. So it's very good information. It'll give you the difference between maybe those not defined as incarcerated and what they need to do, and those who are defined as incarcerated. And that would be important if you're doing contracts with jails. I don't know how many are. I think not the majority. But there are a few out there. I think it still may do that. This slide just talks about your jail, if you're doing contracts for jail employees, which is different than your incarcerated patients. If the jail wants to do contracts for their employees, it's no different than any other public or private entity. They need to be charged accordingly. And the sample jail contract that I talked about has the information on there. You might could add to it, but most of it has the information that you probably need. We don't define in that contract specific specific type of services. We kind of give an idea, like a couple of office visits or a couple of maybe PPD or something, and what the Kentucky Physicians' current Medicaid rate is for those. But that would be something you would have to tailor to your agency if you do that. Contracts with the Fire Commission. Now, the contracts with the Fire Commissions is not one that's somewhat negotiated by DPH. We discussed with the Fire Commission and come up with language for the contract. However, the Health Department has to be the one to contract directly with the Fire Commission. And the importance of Health Department's contracting with the Fire Commission is, according to their policy, and it may be in some kind of law that they have, but I know with their policy, they will only reimburse health departments for designated firefighters to receive hepatitis B. They cannot go to the private physician's office and then to get reimbursed by the Fire Commission. So only the health department. So they and we would really appreciate it if all health departments contracted, so that if there is someone a firefighter that needs their Hep Bs, that this can be handled. Be sure that you do your contract. All the language is already written in it, and you would just put your health department name and their information in there. This would need to be completed prior to providing any services to those firefighters. The other thing is, if you do a firefighter and you don't have your contract done, the Fire Commission will not reimburse you for that until a contract is done. And the same as before, when you set this up under Payor Code 8, you would assign a number yourself, your local health department, a contract code, and then you have to put them in Bridge and Portal. You would need to submit the voucher to the Fire Commission when you send the billing, and I'm pretty sure that in the contract it says that you will submit quarterly. Now, there's not very many of these that you would ever do, so it's not going to be like a lot of money. So quarterly is fine, and that's what we have in the contract. But you do have to send the voucher, so they have to present with the voucher. That's the Fire Commission voucher. and you can find that on their website. And if you don't send the voucher along, they won't pay you for the service. So, a couple of important things with the Fire Commission. Now, when we get to the vaccine administration, the vaccine administration rate is $23. This is already set up in the 501 service file, and this is updated annually. And then the same as with the other contract, you would do the actual cost for the vaccine itself, according to what it costs you, which manufacturer you purchase from. Now, you may notice that the rate for this administration is 23, and then previously we had the DCBS, and theirs was 22. Now, the reason for that is we're in a 2-year agreement with the cabinet DCBS, so we'd already negotiated that. It'll go through fiscal year 16. Once that cycle has been completed, then that rate for administration for the DCBS past employees will go up to 23, or whatever the rate is. If it changes and we have a higher rate, we'll definitely negotiate it for that rate. These Payor Code 8 contracts will not be reviewed the same as the independent contracts are, but we like for you to put them on the L drive, because sometimes I get questions and I need to see them to see what we're talking about, and it's very helpful if they're already out there. Here's my contact information if you have any questions about the Payor Code 8 contracts, the Fire Commission, the DCBS past employees, or any of that kind of stuff. Does anybody have any questions? Well, thank you for your time. If you have questions that come up later, just give me a holler. Ron Horseman will be next to talk about personnel.
Thank you, Janet.
All right. Thank you. All right. Good morning. Not a lot of changes as far as personnel is concerned. You just hit the arrow here. Mine mainly touch on the CH51 contracting is what I will cover, and this is from regulation. Excuse me. Any full-time contract with an individual, if you're doing on a CH51, if that's submitted and it is a position that can be filled through the local health department merit system, we typically do not review those. That would be a very unique situation that we would, because regulations will talk about those substituting for a position in the personnel system. So just keep that in mind. If you are looking at that, it's going to have to be, like I say, a very unique situation. So, and these are just the requirement bullets for when you're filling out the CH51, the different items that have to be included. Really nothing different on that. But here's one that always comes up, and I've got a few different slides on that, but it's talking about a contract employee. If they work the 1,200 hours, of course, typically if it's a contract employee that is a merit position, or if not, usually those will come into Tammy's office, and she'll get them over to me to look at, does it fit in the merit system. But the key thing to remember here is if they reach that 1,200 fiscal year or calendar year, then the health department and the employee may, depending on if it's a returning retiree, if they're going to have to pay a portion of retirement also. So that can sneak up on you, because if you have an employee that worked at another health department somewhere else and then they've moved over to you now, you don't really know how many hours they worked before. So just be ready and ask that employee of their history, and there should be an application that you could get that information off of before they start working with you. Here's another one. All retirees returning to work in an agency should check with KRS. We get a lot of questions in local health personnel. Can they start now? How does that affect them? I will not be the one that's going to jeopardize anyone's retirement. So our advice we'll always tell you, have them and you check with retirement. Those things do change fast as far as retirement is concerned, or it may be an issue that you've never seen before and now it's come up. So there again, if an employee works at 1,200 or more hours per year or a pattern of 100 hours per month, the agency will be responsible for retirement. And we feel if it's 1,200 or more, like all the other employees, they should get the benefit of health insurance also. So keep that in mind. Now, the new item that has hit us this year, we became aware of through another health department, when you have status changes, this really doesn't always affect contract folks, but it could. Say, for instance, they've contracted with you part-time basis for 1,000 hours a year, less than 1,200. And then the day comes, you have an opening, and you say, I think I'll put you as full-time or even increase your hours. Well, what will happen now, if they're doing a 37 and a half, what happens in, I think it's 32 weeks, they will reach 1,200 hours. Okay, so that 32 weeks roughly is going to be 8 months. So what about the previous 4 months? Any hours they work part-time at that time are now subject to retirement contributions. So you could retro back the employee if they're not a returning retiree. They may be asked for a contribution, but the health department for sure will. So that's kind of a catch now. So the key to that is you need to sever your relationship through some type of resignation termination action before you would start them again. And if you do that, then you're fine with retirement. But if you do not, we had one health department that had to come up with almost $5,000, to catch up this time. So when they say the 100 hours or 1,200, it's year to date, fiscal year, calendar year, any way you want to pick it, which is the most advantage for retirement. But just keep that in mind. Just if you're going to change someone's status by contract or in the merit system, be sure that it's a termination there, which contracting 30-day notice should not be an issue to do. Employee contracting hired on the CH-51, we usually say this with one health department, and I'll tell you that'll be my advice every day of the week. And I know there will be certain situations, and I know it happens, that an employee will contract with more than one health department, but we will leave that up to that employee and the two health departments to be sure you don't get in that catch-22 of, I owe retirement now because they combined and worked over 1,200 hours. So this reporting to the START system will all be captured by retirement. So be very careful when you're doing that, because if you ask me, I will say each health department, one, they're the main employee at one health department, the other folks need to contract with them for that employee services. A lot cleaner, may cost a little more money, but and I know it does happen, so I won't say you can't do it. Janet?
I have a question, because when we talk about 52s, we talk about employees. What's the difference?
Well, the 52 is what they would use.
Between the two health
Right,
departments.
when it's between the two. So we're saying if you hire on the CH-51, that's the employee that's hired will be on the CH-51. Now, the other health department wants to use that employee at their health department, they'll do a CH-52 health department to health department. I think slide 22, yeah, that's where that's talked about. But that's a good question, because it's two contracts, really one directly with the person, the other's about the person with another health department. Okay. Here's just the regulations. We'll talk about not substituting for establishing a merit position. Also the multiple agency contracting. That's the two we just touched on, one there previously and the one at the very beginning. And here's just some suggestions, because we have more of this, or it has seemed like we have in times. Especially for full-time, in my opinion, post, that means whether you do internal or your local website or in the newspaper, and I know the least expensive, but put it out there for it. It's just an equal opportunity for all folks, not just who you may know, to be the right person for that. But there again, it's just a suggestion. And I'd say also the application process, not that we have to have those. In most cases, local health personnel does not. But I think completing one of those is a good idea. You're going to have a lot of the information anyway to get them into payroll, into your system. Plus, it gives you the ability to do, unless you sign separately, background checks if you're performing those on folks. You'll have that permission where they're going to be signing of the application, and if you find out other facts about them in the background check, then you'll have rights for, termination where they falsified any information. Now, another one, if you want to send to us, because some programs, I know HANDS is one in particular, for requirements are by regulation, and we have them in our postings, but if you were contracting for someone less than the 1,200, it's kind of at a temporary basis, PRN, whatever, those types of positions, program specific, I think you need to definitely have the application, and we sometimes, or not sometimes, all the time, especially with HANDS, we'll have the program look at the applications to be sure. Because we would not want someone to get hired and then the program, they do not fit, so you will not get paid. They will need to be found another position or terminated. So keep those in mind. We haven't really asked for that a lot years past, but just would not want anything like that happen to an employee. So, and there again, obtain all employee signatures for required documents, because you have orientation for all of your folks that are merit, and all of you may do the same thing for the contracted employees. If you're not, for the most part, you should be. The I-9s, the confidentialities, all those types of forms, just to be sure you're protected and the employee's protected. So.
Do you have a template for when they do post jobs? Do you have an ad, any type of thing they can follow?
Well, we have templates for every classification in the merit system. So if this is going to be one of those, they could use that template, but it would have to be, as I say, PRN on call, less than 1,200 hours. So most of the contracting we may see would be jobs we don't have. So I'm not really sure what they would be contracting for, because they have different grants, and a person may be doing the name, the title of that classification is one we don't see every day. Accreditation has changed the world a little bit, because there's new positions out there that folks are doing different jobs that not in my merit system, but that's something we are looking at. So.
Are there any questions? Okay, thank you, Ron.
Okay, thank you.
Okay, we're gonna play catch up a little bit. We're gonna go through this last bit of stuff pretty quick. If you have questions, you can call me or you can email me. So the most recent templates are on the L Drive, the LHD contracts, contract 16. That's where all the templates for the contracts, the amendments, the information page, these PowerPoints, everything you need is on that drive. Now, if you don't have access to the L Drive, email me and let me know, and I'll see what I can do for you. Contracts are due May 1st. School contracts are due no later than April 30th, unsigned. Okay, when you save your contract onto the FY16, you're gonna, if you use the final FY15 contract, make sure and take that name off, final. Because when I save it and I rename it final, that means I am done with that contract. It's been reviewed. We're not gonna do anything else with it. So make sure if you use that FY15 as your template, that when you save it on to the new FY16, that you don't save it as final. Same thing. Okay, do not email me your contracts. Do not send me contracts that have Social Security numbers on it. We don't require that information. Save all of your contracts on the L Drive, and always email me when you have a new contract on the L Drive. Don't assume that when you call me about a provider number, that I'm going to think that I'm going to know that there's a new contract on the L drive because I won't know. Okay, provider numbers are assigned by us. And I wanted to cover this because I still get a lot of questions about it, and so we'll go through it really quick. At the top of your contract, you've got your provider number. The first part of the number is the 16, which is the fiscal year, and then you've got the three numbers, and that's your HID number. It could be 009, it could be 301, 316. And then the last 5 numbers are the numbers that we assign here. So if you look at this one, it's 16000K1300. So 16 is your fiscal year, 000 is your HID number, K1, which is physician services, and then 300 was the next number in that line that we would assign. And it's the same thing for the 53M. The 16 is the fiscal year, the 000 is the HID. The 260 would be for a room, and then the 04 is just the next number that we had in line to assign. And that's how we assign those numbers. You can read that about the Board of Health member contracts. When you make a correction, please, please, please delete the O contract off of the L drive. Do not have 2 contracts on there. I won't know which one. Sometimes it's hard to tell if they both look alike. I don't know what the changes are. If you want to keep the original in your file somewhere, that's fine. The information, I hope, will be on the website by the end of the month. But everything is on the L drive. You can find it there. And you can contact me, Mark Tibbles, or Janet. These are our phone numbers and our extensions. And that's the local health.helpdesk@ky.gov. Are there any questions? I'm sorry we went so quick. Okay. Christy Royalty will come up next to talk about family planning.
Thanks, Tammy. Good morning. We'll just go over the same contract process as it was last year. There's been no change in how you would do that. There we go. Types of contracts allowed for Title X funds within the Kentucky Family Planning Program. Personnel contract for a mid-level clinician or higher to perform family planning clinic services on site at the local health department. Contract with the mid-level clinician or higher to refer patients to or for insertion removal of methods such as implants or IUDs. Contract with the physician to refer patients for sterilization procedures. Contract with outpatient surgery center or hospital for preoperative surgery or post-op for sterilizations. And contract with an agency to provide family planning services indirectly. The personnel contract for the APRN MD to perform family planning clinic services on site. This type of contract should include provider credentials, scope of services, hours of work, and payment rate, and shall identify who will carry professional liability insurance, the contractor or the LHD. The contractor shall adhere to the family planning program guidelines outlined in the CCSG and the AR. All billing of third-party payers and self-pay patients shall be the responsibility of the health department. As this continues, this is for the insertion and removal methods for implants or IUDs. This contract should include provider credentials, scope of service, and payment rates. The contractor must carry professional liability insurance. Patients shall not be billed by the contracted provider. Contractors shall bill the local health department directly for services for self-pay, uninsured, or underinsured patients. And the medical record for the service rendered shall be forwarded in a timely manner to the health department prior to payment of service to the contractor. And as this continues with the insertion removal methods, when the services are covered for reimbursement by a third-party payer, the local health department shall not bill or the contractor shall bill for services directly to the third-party payer. The local health department shall not bill third-party payers for services provided by a contracted provider off-site. For self-pay patients, the local health department shall provide the device, the implant or the IUD, for the contracted APRN or MD to insert. The APRN or MD shall not bill for the device. For patients with third-party payers, the contracted APRN or MD shall provide the device and bill third-party payers for the device and insurance fees unless underinsured. Contract rates for services should be aligned with current Medicaid rates, and then we also have attached on the L drive the Family Planning Program approved CPT codes. And these just show the codes for, and these are with the updated DPH preventive Medicaid rates, insertion and removal of IUDs, insertion and removal of an implant, removal and reinsertion of an implant, and the limited pelvic ultrasound, which may need to be used to check IUD placement. Contract with the physician to refer patients for sterilization procedures. This type of contract shall include provider credentials, scope of services, payment rate. For vasectomy, the contract should define whether the post-op sperm count is included in the negotiated rate or will be billed to the local health department separately. Again, the contractor must carry professional liability insurance. Patients shall not be billed by the contracted provider. The contractor shall bill the LHD directly for services for self-pay, uninsured, or underinsured patients. The medical record for the service rendered shall be forwarded in a timely manner to the health department prior to payment of the service to the contractor. When the services are covered for reimbursement by a third-party payer, the contractor shall bill for services directly to the third-party payer. The LHD shall not bill third-party payers for services provided by a contracted provider off-site. The federal sterilization form shall be signed in the health department or in the physician's office for postpartum sterilizations at least 30 days prior to the date of surgery, and no more than and the procedure must be performed within 6 months' time. A copy of the signed federal sterilization form shall be sent to the contracted provider or to the health department, depending on where it was signed. The LHD must file a copy in the patient's medical record. A consultation with the contractor will be scheduled by the health department, and appropriate counseling to include the permanency of the procedure, failure rate, the risk of ectopic pregnancy will be done at the time the consent form is signed. Contract rate for services should be aligned with current Medicaid rates. And here are your CPT codes for these procedures. Tubal vasectomy and office visit. Now the office outpatient visit has changed. On the prior contracts it was a consultation code, but Medicaid no longer covers those. So this 99214 is for an established patient, and what I omitted on this is 99204 is for new or initial patients. So those would be the codes that your contracted provider would use. Now this is for contracts with outpatient surgery center or hospital for pre-op surgery or post-op care for sterilizations. Again, the contractor must carry professional liability insurance. Patients cannot be billed by the contracted provider. Contractor shall bill the LHD directly for services for self-pay, uninsured, and underinsured patients. The medical record for the service rendered shall be forwarded in a timely manner to the health department prior to payment to the contractor. When the services are covered for reimbursement by a third-party payer, the contractor shall bill the services directly to that payer, and the LHD will not bill the third-party payer in that instance. Contract prices for services for uninsured clients should be aligned with the current Medicaid and Department of Public Health approved rates. Prior approval for the procedure must be obtained from the LHD. The contractor agrees to provide necessary pre-op lab tests as indicated by patient history and are required by accepted medical standards. Female patients must have a negative pregnancy test prior to the procedure being performed, and the contractor agrees to conduct counseling to patients regarding the elective sterilization procedure, including complications and discomforts that may be encountered and the proper follow-up care. And this slide just talks about the consent form. It's the same as the previous slide on the consent form. And these are just the hospital codes, pre-op, post-op, anesthesia for tubal, and anesthesia for vasectomy. Do you all have any questions? If you do, just give us a call or email. Thank you.
Thank you, Christine.
Hi, this is Susan Lawson with the School Health Programs, and this is new to me, so if you have any questions, please email me and we will work through them together. First thing you want to consider with your school health contract is you want to be sure that you clearly define the specific roles and responsibilities of each agency, and the contract is dependent on the local resources and policies. You want to provide understanding. Make sure that it gives direction to the personnel who's going to be providing the services. You want to make sure that you meet with your key agency personnel to assess the needs, the community needs, school needs, services that maybe need to be provided. You will want to review, update, and renegotiate your contract annually and talk to those key stakeholders. You want to make sure that you use the correct contract verbiage, school satellite clinic site, and to define the school-based health services. They're described in 907 KR 1175 and our federal Medicaid services under the Disabilities Education Act required by the schools. Services provided at satellite clinic sites are billed through Medicaid coverage under an MCO. Do not use the term school health coordinator in the contract language, as this is a mandated position by the state for school districts. Some of the things you will want to consider with your contracts is school districts are responsible for writing their own health policies and procedures. FERPA governs the student education records, including the health records, and I'll talk about those in a minute. The key stakeholders you want to include the school superintendent, the school health coordinator, 504 and IEP coordinators, and the special education director coordinator. The Kentucky Department of Education is the lead agency of the school health services, working in conjunction with the local health departments to fulfill the requirements. The school health records required under the 701 KR 160 is the immunization certificates or exemption certificates, and the new physical form combined with for initial entry in the 6th grade, and also the BMI. The sports physical form, you want to make sure that staff is filling that out completely in those records. The vision, dental exam screening forms, screening programs, vision and hearing, cumulative health records to include medication and clinical procedures, health room visits, documentation, parent-guardian communication, health exams, screening information. It doesn't have it on here, but the HIPAA, the release of records, that kind of thing, you want to also have in there. The local health department considerations, you want to make sure that you review these points when developing your contract. The nurse, the clerk, fringe salary, training, any of that type of cost, the scheduled hours, and who's going to be supervising that person by the local health department. Requirement of nursing substitutes, the office equipment, maintenance, and repair of that equipment used, what those job responsibilities will be, and the services to be provided by that person, and possibly what services are not going to be provided by that person. Attendance on field trips and home visits, what is required for that, and the training requirements for those nurses. Individual school health policies, the FERPA HIPAA regulation, again, the consents signed by the parents to share the health information. You want that in the record. Maintain school health records and IC data entry. Make sure that you have adequate facilities to provide the services, and the services provided for faculty and staff, what is going to be in included in that. Responsibility for providing and sending out consent forms for local health department, school health services, and the nursing staff should carry the professional liability insurances by the local health department. Delegation, training, supervision of unlicensed school personnel, the delegation of insulin. I won't go in that, you can count that. What is needed for that and what is required to be documented with that. The Kentucky Board of Nursing proposed this amendment, and it was passed for the insulin administration in the school setting by the unlicensed assistive personnel. Make sure that you're familiar with that. I won't go over the FERPA HIPAA, just make sure that you have those documents in the records. The IEP, they're to be billed through the schools. Provider Type 21, the local health department role in IEP services are to be specifically written. Things such as will the nurse provide or not provide services, sharing the student IEP list names, adding the local health department school nurse as part of the IEP team. It's not always necessary. It depends on the service needed. And if the local health department provides IEP services, reimbursement mechanism is needed to be, I guess, worded out for the local health department contract. If you have any questions, just email me or call me, and we will work through it together. As I said, I'm new to this, so I'm not sure exactly what questions are going to come out. So just email me. Thank you.
Thank you, Susan.
Are there any questions?
Good morning, or merry afternoon. My name is Trina Miller, and I am with the prenatal program, prenatal nurse consultant and program coordinator. And at the end of the PowerPoint is my contact information, so feel free to give me a call or email if I can be of any help or if you have any questions. Prenatal care is one of the core public health services, and it serves as a primary strategy for reducing infant mortality and improving birth outcomes. So we're looking at the health of the mother and the health of the baby. All local health departments must assure that prenatal care is available for pregnant women in their jurisdiction, either directly or through a referral to a qualified prenatal provider. And so the contracts are the mechanism to fulfill that assurance. Local health departments need to assure basic care and medically necessary prenatal services are provided to patients participating in the public health prenatal program. That public health prenatal program, that is when women, and I'll go through that in a moment, qualify for the eligibility requirements. And so we have referred to that prior as maternity services, prenatal program, that trying to make that consistent as the public health prenatal program. And then in the AR is a list of the description of services for the prenatal program, public health prenatal program. The core public health block grant funds should be used to assure routine prenatal services for those women who are eligible for the public health prenatal program. And in the AR, it lists that eligibility. That is pregnant women who have an income at or below 185% federal poverty level and have no other payer source. They're not Medicaid eligible or other payer sources. If there are women that are would need other services beyond what's listed in that AR, this is what this bullet is referring to, that local health departments can make local decisions about judiciously covering other services for income eligible patients according to their local budget, patient needs. So the list in the AR is not saying that's the only thing that you could do, but that is, we want to at least be able to assure they're getting those needed services. So a reminder about the contracts. There are 3 different contract templates available on the L drive. These are pretty much similar to what was listed as a contract last year. They have changed over the years, since several years prior. Want to be sure to utilize the FY16 prenatal contract templates, one of those 3 that are listed. I often, in reviewing contracts, will see contracts that may be from a template 4, 5, 6, 7 years ago. So we need to look at what is the instructions, the guidance, and templates that are available. Also make sure that you refer to the most recent AR and CCSG for the prenatal matrix and language. Often I do see language that is still refers to the PHPR, or language that maybe is in contracts that were from 6, 7 years ago, or that such. So we just want to make sure that our language that is current. Also, there have been some changes in what has been listed in the AR, the CCSG, from several years prior. So those are referring to the PE. You don't want to just use the same contract you may have used several years ago, because that time frame has changed. Some of those, that information has changed. So be sure just to look at the current templates. Also, a reminder is please do not use statements that single out any race or group, such as saying illegal population of people. We don't want to use that in the contract language. The population that would be eligible for the public health prenatal program is those that meet that eligibility criteria. Like I mentioned already, don't use language from previous versions of the AR or referring to public health prenatal or referring to public health practice reference. That is now changed as the core clinical service guidelines. Also, I have provided this on the L drive, just a list of some guidance documents that has required language, and so that is for your benefit and to help give some instruction or guidance. But please don't copy and paste that instruction or guidance into the contract, because that's not contract language. That's just some information to help guide us as we are writing the contracts. So these 3 types of contract templates. There is one for services, contracted on-site prenatal services. Yes, template A. And that is for prenatal services that are provided at the local health department by a prenatal provider. So if you have someone coming on-site to the health department and they are providing prenatal services, then this template would be the template to utilize. The second template is the clinical provider referral agreement. This is for health departments where patients are referred to a prenatal provider for clinical services that are not performed at the local health department. So often would say you may use a referral method to refer patients out to a provider, then this would be the template to utilize if the provider is not coming to the health department to perform services, but you're referring patients to a provider elsewhere. And then often we'll get some contracts in that are for services that may be just ultrasounds, or for NSTs, or for some type of prenatal service that is provided not at the doctor's office or not at the health department. They may be provided at the hospital. So there is a hospital outpatient testing template. So these are for prenatal services provided at the hospital if not available in the health department or the contracted physician's office. This is not a contract that you have to have, but there are some counties or health departments that would utilize this contract. So a health department would basically need to pick either the first one, a contracted on prenatal services, on-site prenatal services, or pick number 2, the clinical provider referral agreement. The third one is optional if that would fit your needs, but is not required. That hospital template, the public health prenatal program does not cover the cost of inpatient hospital stays, so that is not necessarily, just because it says hospital does not necessarily refer to inpatient hospital. They're staying for 2 days and be monitored or that such. So that's more for your individual services such as NSTs or amniocentesis or ultrasounds. A couple more reminders about the templates. There is some required language in the templates, and there is some additional language that is often used that may be applicable or helpful. So I do want to make sure to mention the required language, and I'll go over that in just a moment. Like I mentioned before, do not use prior contracts as your templates, as there's changes in language or abbreviations. There's also been some changes in presumptive eligibility where there had been covered services up to 90 days. That has changed, and covered services are only up to 60 days depending on when the woman is deemed eligible. So we need to make sure to be mindful of that. We're not just utilizing a template or a contract from prior years, because there can be changes in language. I've tried to make the templates useful in such that there are, you can just copy and paste the appropriate template language into the current CH53 form. So hopefully that will be helpful to everyone. If there's language in the template that is not required, but the other additional language under like the scope of work that may not apply to this contract, then you could delete that language if it's not applicable. What the required contract language, I'll go over that, what needs to be included is, number 1, it will say in there, prenatal care providers must be licensed in Kentucky and board certified in obstetrics, family practice, or midwifery. These need to be certified nurse midwives. As I just said here, any midwifery service must be provided by a certified nurse midwife. If prenatal care is not under the direction of an obstetrician shall be available for consultation. Providers must act within their legal scope of practice and ensure they have professional liability insurance for the services they provide. So this is required language, and you could just from the template copy and paste this into the contract, or vice versa, copy and paste the other language into this template. Number 2, the contract will need to have this listed: prenatal care, regardless of which provider is delivering the care, must follow the most current guidelines of the American College of Obstetricians and Gynecologists, that we call ACOG, and adhere to the clinical course service guidelines and the administrative reference. So I'll be looking for that language in the contract when I review that. Number 3, in the templates there is some language that you can utilize and pick which is appropriate, but contracts do need to specify compensation for services. Like I said, the contract template provides suggestions. Those options, I'll just kind of mention those briefly. Some contracts and local health departments may work with their providers to provide an hourly arrangement, saying the health department shall pay for services based on hourly rates. So that may be an option that the health department may utilize. Or they may do a fee for service, and the contractor and health department agree that the contractor will bill Medicaid and third-party payers for services provided to covered patients seen at the health department. The health department will pay the contractor for agreed-upon services for program-eligible prenatal patients with the submission of appropriate documentation for services. So that is some optional language that is in that compensation payment section of the template. And so when you look at that, then that can help to give some guidance on what method you may utilize. It does need to be addressed and listed in the contract. Fourthly, compensation for services to any provider shall be at the current Medicaid rate or a lesser agreed upon amount. Payment is to be considered in full for the particular service. The patient shall not be billed for these services. The funding is provided for those women that qualify and are eligible, and so these women, we don't want them to, there to be a barrier to services, and so the funding should be utilized to pay for the applicable services, and the patient should not be charged for those. So that needs to be included in that compensation payment section. So those are the four items that I will be looking for, particularly when reviewing contracts, and that will need to be, the language needs to be in there in order for that contract to go through my review process. So the finished contract should include the contract description, the scope of work, compensation payment section, your billing procedures, and then of course the language that AFM requires for the contracts, certainly. Some resources are listed here in the PowerPoint. They're also listed in that guidance document that's on the L drive. Like to make sure to refer to the most recent CCGS, should be CCSG. And then also the AR, because I do not utilize the PHPR when you refer to the program matrix. There's the prenatal program website, the physician fee schedule. Here's my contact information. I'm going to, are they just minimized? I'm going to go through all these. I'm going to briefly just show you so you can recognize when you see it. This is the template one. This is for contracted on-site prenatal services. So I just kind of want you to be familiar with this. Look at this here. These first four bullets is listing that required language. And so we just kind of would just fill this in as appropriately. And of course we want whatever's in the contract then to be applicable and followed. This is a scope of work I was talking about. And so this is language that is often listed in the contracts, the language I would encourage or suggest. Some of this, of course, may not be applicable particularly in all senses of your particular arrangement, but do please look over this. This is that compensation payment section where there's A or B option, depending on what your health department utilizes. So this is some language here that can be utilized. Billing procedures. This is that number one is compensation for services, payment in full, patient shall not be billed. That was listed there as required language, so be sure to put that in there and utilize that. The 2, 3, and 4 is suggested language. So that is your on-site contracted services. The referral template looks similar. You'll see it here, clinical provider referral agreement. It has your 1 through 4 here, like here where you'll see the sections where it's highlighted, or it's not highlighted, but I'm highlighting it where it says required language. And just like below in the compensation billing section, I have it in the brackets required language, just to be sure to include that in your contract. It has scope of work. There is some information you'll see down here in number 5 that lists the ACOG practice bulletins if you need to share that with your provider or just for our own information where that reference is, that why we're suggesting and encouraging that practice. So anyhow, there's plenty of language here to look through and to check out. Here's your compensation payment section that you need to pick one of those. Once again, there you see some required language. So hopefully that will be helpful to utilize when doing contracts. And this then just is the hospital outpatient testing. Like I said, this is not required, but it's available if you would need or utilize this. And it talks about the purpose of this here in the contract description. And then it lists some language here that would be applicable. It lists the services lab services and procedures that are in the current administrative reference. It has some billing information that you could utilize for language. Are there any questions? I said my contact information is on the guidance document and in the P drive, and feel free to call or contact me if I can be of assistance.
Thank you, Trina.
Good morning. What's left of it anyway. This is Melody Stafford with the Kentucky Women's Cancer Screening Program. And kind of like what Christy says, there's not a whole lot of change here, but we're always available for any questions that you might have. The first thing I'd like to show you is the contract rate sheet. It looks the same as it has in the past. There's a place where our CPT codes go, our technical, professional, and global outpatient rate. Those are broken down, and those rates are based upon Medicare Part B rates. So you can always negotiate those rates with your provider to a lower rate and make a little bit maybe. The next thing is it should only have the CPT codes on it that will be reimbursed by the contracted provider by the local health department. Some people have put the whole CPT code list within their contract, but that's not a good thing to do. We just want the ones that apply to that particular provider. And if you look below, there's the link to the current version of the CCSG. If a local health department, if you add additional information or language within the body of the contract outside of the template form, then you will be responsible for those additions and or changes. And it may be made that require additional services from a provider, but they must at least provide the minimum requirements listed in your CCSG follow-up section. I've listed the codes that we have now for the KWCSP, and I think we only had maybe 4 or 5 new codes, and they were all under lab and pathology. So the new codes were 88172, 88173, 88305, and 88307. And those codes deal with cytopathology and surgical pathology. Here are the breast surgeon codes. I know a 19 code or a code that starts with 19 cannot be separated into professional and technical components. They all have to be under a global rate. And of course, the evaluation management and preventive codes go with those. Then we have the gynecologist codes. And the same thing, I don't think we had any new to that list. Or radiologist and the anesthesiologist. If the hospital employs the surgeon and anesthesiologist and pays their salary, then the hospital may bill for the service that these providers perform. So the individual providers should not be allowed to bill separately. That's billing twice, so be sure to keep a lookout on that. The same thing about lab specimens, or if they are evaluated at the hospital lab instead of being sent out, then of course the hospitals can bill for that service. Just remember, only one provider may bill for each service. So the local health departments, you guys will have to determine whether it should be the hospital or the physician by discussing their arrangements at contract negotiation time. Here are some other procedures that can be paid with other funds that you might have. They may be used frequently within your program, but the federal government will not let us reimburse these with federal funds. So if you have a question about one of those, please call us. If you think
there might be something that we can do to help you. There's things are always changing, and you guys know that as well as anybody. But don't, if there's just something that has to be done, call us, and we will try to help you work through that.
Do you want them to write that in the contract next to those codes? Do you want them to mark that in the contract, or?
They can actually do that, but we would prefer it not to be on the template, the KWCSP template. See, I was short and sweet. I'm going to get you all out here for lunch. The contact information is there on the back, and any one of these people are very highly skilled and very highly knowledgeable about the program, and so we're all open to hear and take your questions. So at that, do you have any questions? Gee, guys, thanks. Call us anytime.
Thank you, Melanie. Well, that is it for FY16 contract training. Are there any questions about anything? Well, once again, I want to thank all of you all for all your hard work that you do on these contracts. I know that you have many hats that you wear in the health department, and I really appreciate all your hard work and all that you do for me.